Good morning, everyone. We're going to go ahead and get started right on time because it is certainly an interesting day in healthcare policy. This is another one of those day after kind of events that I don't think any of us exactly planned for today. But for those of you who I've not met before, I'm Ken Yonda. I'm the CEO for Community Health Choice. For those of you not familiar with Community Health Choice, we're a nonprofit safety net health plan. As we like to say, we're kind of Blue Cross for poor people is our particular market niche, but we're an insurance company that provides coverage for nearly 500,000 people in the Houston metropolitan area. We've grown very rapidly, and things that have been happening in Washington and in Austin are very influential in our business. And so it's I feel like a very good thing that Community Health Choice is one of the sponsors for the Baker Institute's Health Policy Forum, which is what we're doing today. Having an informed conversation with experts in the business is actually an important thing. Even though it may not be politically correct anymore in the United States to have experts on subjects, I think it's important that we in fact do have both experts talk to us about some of these key issues that face us in a time of uncertainty in healthcare policy, and having all of you here as well is really important because we want to hear your voices as well. So thank you all very much for being here today. I look forward to the conversation, and I look forward to seeing you guys at future events like this that we have for the Baker Institute Health Policy Forum.
Thanks very much, Ken. Good morning. My name is Vivian Ho. I'm a health economist here at the Baker Institute, and thank you for joining us this morning. We planned this event a little bit after President Trump was elected, and right after that happened, we got requests from a number of our roundtable members and from the Health Policy Forum members to say, what is going on in healthcare? We'd like to hear about what the people on the front lines are dealing with and how they are facing what is happening in terms of health policy developments. So in order to have an event with such prestigious panel members as we have here today, we had to schedule several months in advance. We had no idea, back in late March, I thought, oh, no one's going to want to come to this event. They're not going to be interested anymore. And then yesterday happened, and Brenda Laymans, who's our program coordinator, just suddenly, the phone was ringing off the hook in terms of people changing their minds and saying they want to be here today. So thanks very much for coming, and thanks for the Health Policy Forum for supporting events like this. So I'm not the center of attention today. I'm thrilled to be having three excellent speakers for you today, and I'm just going to start introducing and get out of the way. I do ask that you hold your questions until all three have spoken. They are going to speak for about 15 minutes, so we have plenty of time for questions and answers afterwards. We're aiming to finish around 9:15. I'm not going to read the official bios on the program to you, but I do encourage you to read them because you are going to see that these speakers, even with their prestigious positions they are in now, have backgrounds from all over the healthcare sector and really all over from policy in general. And I think that's going to inform what they speak today about. So I'm first going to introduce Dr. Benjamin Chu, who is the CEO of Memorial Hermann Health System. And let me just say something. Memorial Hermann, of course, is one of the premier healthcare systems here in the Houston area. He comes to us from Kaiser Permanente in California, which is well known for its reputation. It's just become a behemoth there, but in a good way because it delivers high quality and affordable healthcare. And I almost think, we wouldn't have these healthcare problems if everyone was just like that organization. So Memorial Hermann actually takes care of a large number of uninsured patients here in the Houston area, and you're going to sort of hear from that particular perspective as well. So with that, Dr. Chu.
Thank you very much, Vivian. And really, I thank you for inviting me to this forum. Who knew, right, that all of these things would be happening all at once? I'm not going to speculate as to what's going to happen with the Affordable Care Act or the repeal and replace, just simply because, I think that it would just purely be speculation. I thought I would really talk a little bit about delivering care in this time of uncertainty from the long view, as opposed to day to day what's actually happening in the policy arena, in the payment arena that could affect us. I think that one of the key key focal points of the Affordable Care Act as it was constructed in 2011 was to really begin to address the issue of can we actually transform the delivery of care from a system that is largely relatively fragmented and siloed and segmented to one that's much more patient-centered and focused on coordination of care, with the idea that ultimately, one of the key drivers of healthcare is going to be the cost of healthcare, and you see that, playing out in a lot of different ways. Right now, the recent estimates of percent of GDP going into healthcare in the next 5 years or so, it's estimated that we're going from a little over 17% to north of 19%. And as you know, the insurance world, which Bob can talk a lot about, has actually started to move to much more high deductible, much less, for at least for the consumer or the patients, a larger cost sharing. Even companies that prided themselves on providing really very good coverage are moving towards high deductible plans. About a third now of all commercial insurance is high deductible, which tells you that unless we begin to look at a better coordinated, transformed delivery system, we probably are reaching a point of unaffordability, and then Bob comes to us and tries to squeeze us on price all the time, and we'll resist
in a very nice way,
in a very gentle, nice way, right? And then of course we want to try to make sure that we have enough funding to do the things that we do. But at some point, the delivery system has to look at, where are the wastes in the system? How are we going to actually do a better job? And really, the driver here is, I'm a clinician. I'm a primary care doctor by training. The real focus has to be, well, what is the value to our patients? How do we actually deal with delivering what's necessary to patients, no matter what they need, right? And of course, the population is so complicated. We think of healthcare as being uniform in some ways, but really, you look at the population and you have to think about it in a segmented way, not a segmented way in a bad way, but there are tiers of need, right? You have high need patients, older patients with lots of disability, and the approach has to be a little bit different than the ones who are, just coming out, the young and healthy who think they're going to live forever, right? So we're trying to we're trying to create a policy for a world that has to encompass all of this stuff, and to figure out ways to pay for it in a manner that delivers on equity principles, as well as making sure that the resources used are judicious, right? So many of the things that we had been working on across the country and in Houston also is how do we actually start coordinating care in a better way, right? So the Affordable Care Act contemplated all of these accountable care organizations, which brought doctors and care deliverers into really team-based care, trying to figure out, with an episode of care, with a segment of a population, what are the ideal pathways that you can articulate, and what should the resource utilization be, right? Because if you actually look at resource utilization for the same thing, we're all over the place in healthcare. And actually, you could see that regionally. If you go to the Northeast, it's different than in the Midwest, and California is very different than Texas. So the question is, what's the right approach? Now, there's always going to be local conditions, right? Local factors. But when you think about it from the patient's point of view, and the patient, looking at it from the patient's end-to-end patient care experience, that shouldn't be that different, right? I mean, patients come with a certain condition, they want to get better, they want the best outcome, and the provider world should be able to coalesce around a sort of a portfolio of approaches that could actually get us to the best outcome. right? And I think that we're just beginning in healthcare to define what those outcomes are and to begin to understand what the resource utilization should be. You look at imaging across the country. I mean, there is easily a double or threefold differences in imaging use for the same conditions all across the country. And I don't want to say which is the right way or the wrong way, but at least now, with our ability to track with electronic health records, which have their problems, I know, but electronic health records at least give you the ability to create population care registries that you can track over time, so we can begin to learn about what's the right way and what's not the right way, what could be a safe utilization of resources and what's not, right? So I think that we have to make sure that we stay focused on that. And I actually think that in this period of great uncertainty, we don't know whether the payment system is actually going to come and catch up with the kinds of things that are necessary. If you actually look at deliveries, the technology that's available to the delivery system, just think about how we do things outside of healthcare, right? Most of my banking is done with my cell phone right now, and I know the millennials out there are all looking towards, digital visits where you don't actually have to come face to face. The technology actually is there that allows us, for most people, for most conditions, to deliver care without a direct face-to-face visit. It allows us to break down both the geographical barriers to care as well as the temporal barriers to care, right? But the delivery system hasn't quite caught up with it, and neither has the payment system. Because when you really think about it, if you can take care of somebody's problem in the middle of the night with a video visit, and a couple of key ways to, like a kid with an ear infection. How many of us have had to be up all night with our screaming child because of an ear infection, and having to drag that kid into an emergency room or urgent care center, when the alternative might be you get in touch with somebody who knows your history, can pull up your chart, the child's chart, can do a video visit, maybe have one or two little applications where you can actually check on the conditions that could be operating, and then deliver on a protocol. I mean, that's all possible to do these days, but it's not easy to do. It's not easy to get paid for it, and the platforms haven't been developed to do those kinds of things. So I actually think that we have to continue down that pathway, because if we're going to be looking at the cost of care and trying to make sure that we're judicious about it, we have to start bringing in those kinds of technology that would actually cut down the cost. But here's where I think it's a win-win. It will not only cut down costs, but it's a win-win for our patients, because it's so much more convenient. It's much more direct. There's no waiting to make an appointment. There's no having to live with morbidity or screaming kids, whatever it is. You can actually start to do those things on a real-time basis. I think the other thing that we have to begin to think about, and what was contemplated in these accountable care organizations is, we actually are fairly passive in healthcare. We basically catch people at the end of the disease spectrum, where we try then throw a lot of resources in to try to optimize the outcomes for somebody. And I think that there's really increasing appreciation for the fact that there's got to be a better balance, right? I mean, I came from Kaiser Permanente, where we were very prevention oriented, and people stuck with us for, the average member was with us for 15 years. So, as a health plan, I could make an investment in preventive, in achieving preventive guidelines, maybe even in trying to change somebody's lifestyle, and then catch the benefit 10, 15 years down the road. Our healthcare system isn't configured like that. I'm in a hospital system now, so I have to fill the beds in order make sure that Bob pays me enough money to do the stuff that we need to do. But you know what I'm saying, that what was contemplated was a delivery system that could put these in better balance, right? So for example, in the 1115 waiver, we have a lot of programs out there through the delivery system reform incentive pool plan, where we put behavioral health resources out there because there just weren't any out there. So and really where we have to go is much further upstream, right? If we don't go upstream and start to think about, what makes a healthier, more vibrant community, right? It's getting people to go out and exercise more, making sure that there are good food choices. I mean, we've spent a lot of time. We have another district program which is school-based, and we have to begin to influence what's served in school lunches. Whether the balance between the academics, the didactics, and the physical health for children. We have to teach kids to learn these habits at some point, and that requires all of us to begin to move a little bit upstream. So I think that there are a lot of issues there. Plus, the demographics is changing, right? When you think about it, I sort of make fun of the millennials because they're all, they all. Believe me, I have kids and they're millennials, so they're making fun of me more than I'm making fun of them. But when you really think about the changing demographics, both in terms of the population as well as the changing demographics of the providers of healthcare, we actually have to change. We have to embrace some of this new technology to be able to reach different pools of people and actually maybe use them in a way that can help us get upstream, right? Because you look at the millennials and they're all chatting with each other, the social networking, whether it's Facebook, whatever it is, Snapchat, we don't really use those tools, and those tools actually are very powerful. They can actually influence behavior, they can influence our attitudes and values towards health. And the healthcare system, we're still waiting for people to come into the ER and be admitted. All important, by the way. I'm not saying that it's not important to actually have the capabilities to do that, but if you really think about how to deliver care in a time of uncertainty, we all have to focus on what's really the right thing to do for the largest population. And I actually think that it challenges us to think about what's the portfolio of activities that will, in the long term, deliver on the promise of health much more than in the short term. So I'm just going to stop there.
Well, thanks so much. That was excellent. Again, we'll hold the questions until all three panelists have spoken. So we'll move to Ann Filippic. Ann Filippic is president of Enroll America, which is, maybe some of you have heard of the organization, maybe some of you haven't. It's based in Washington, D.C., but it has played a tremendous role in terms of getting people enrolled in insurance marketplaces under the Affordable Care Act. And it's done so through a combination of very highly trained, well-targeted data analysis, but combined with a personal touch, and has really reached out and enrolled millions more people in health insurance who wouldn't have been able to sort of navigate healthcare.gov otherwise. So with that,
great,
Ms. Filippic.
Thank you, Vivian. And I think I'm actually going to use the podium for my remarks, if that's all right.
Sure.
So yes, it's really wonderful to be here with all of you today, and just a special thank you to Vivian, to Rice University, the Baker Institute for Public Policy for inviting me to be here and part of it. In a moment, I am going to share a little bit more about Enroll America and what we do. I want to talk about the coverage gains that we've seen over the past 4 years, which we're particularly proud of, and also a little bit about, through the work that we've done, what have we learned about what consumers really need. I think sometimes people think, if you build it, they will come, right? Great movie, Field of Dreams, but actually when it comes to healthcare, that's not always true. That people can really want health insurance, and there can be good options available to them, but they may not really understand how to connect with it. So there's a lot that needs to be done, and that's really what Enroll America has done to help connect the dots for consumers. Before I get into that, though, I think I really would be, I don't want to spend the entirety of my remarks talking about the bill that was passed in the House yesterday, but I think I'd really be remiss if I didn't note it, because I think for those of us that do work on coverage issues, it was a pretty alarming moment for us. I will say that there's a long way to go before this would become law, but independent analysis has shown that a lot of the progress that I will note that we've made in increasing coverage would be erased. Millions of people would lose coverage. The cost of coverage would go up, especially for low and middle income folks. And a lot of the protections that have been core to the Affordable Care Act for folks with pre-existing conditions, the essential health benefits that are guaranteed through that would no longer be guaranteed for folks across the country. So I do want to say that a lot of the details I'm talking about and will be talking about momentarily are built upon the core assumption that there are quality, affordable coverage options available for people. If there are not, then you can do a lot of outreach and it doesn't really matter much because they're not going to enroll or keep that coverage. So this is a really alarming moment, and I don't want to skip over that before I get into talking about some of the lessons that we've learned. So with that, a little bit of background about Enroll America. Enroll America was founded shortly after the passage of the Affordable Care Act. Our mission is really to maximize the number of Americans who enroll in and retain health coverage through the ACA, and as I said, to really help them through the process. It was envisioned as a temporary organization, a burst of energy and organizing to shepherd enrollment through the most difficult and critical early years. And we knew just because new plans and coverage options were available didn't mean that everyone would automatically understand them and take actions to enroll. So someone would really need to actually find the millions of people where they live, connect with them, and answer their questions and help them through the enrollment process. And that's really what Enroll America has done. We've worked with more than 6,700 partners across all 50 states and the District of Columbia. And in that time, we have seen an unprecedented expansion of coverage. And I just want to run through some of these stats because I may be biased, but I think they're pretty staggering to think of how far we've come in terms of the reduction of the uninsured rate in this country. We've cut the national uninsured rate nearly in half, from 16.4% to 8.3%. In fact, the rate dropped in every state and the District of Columbia. In almost every county, it dropped by more than a quarter. Remarkably, this is one of my favorite statistics, the number of states with uninsured rates under 10%. In 2013, there were only 5 states. In 2016, there were 37 states. Again, that's with uninsured rates under 10%. And every single demographic group that we track at Enroll America, all races, all ages, men and women, rural and urban, they have all seen their uninsured rate drop in the last 4 years, with some of the largest gains coming among young people and communities of color. And in this fourth open enrollment period, which ended at the end of January, we saw more than 12.2 million people select plans through the federally facilitated and state-based marketplaces created by the ACA. Enrollment outpaced previous years in nearly every state-based marketplace, and as of January 2017, which is the latest data available, 16.7 million people have enrolled in Medicaid since September 2013. So this is really incredible progress, and that is part of, to go back to where I started, why yesterday's passage of the American Health Care Act in the House is so alarming for so many of us. In an earlier version of the bill, the Nonpartisan Congressional Budget Office actually estimated, so this is a nonpartisan group, that 24 million people would lose coverage within the decade through these provisions. Unfortunately, the House actually moved forward yesterday with that vote before CBO could release an updated score based on the amendments that were added to the AHCA. We actually expect those numbers to come out in the next week or so, but again, independent analyses and actually folks that used to work at the CBO are predicting that that number of folks that could lose coverage could actually be higher. So that's really scary. I think really incredibly alarming now that, and I think for those of us that do this work, and I can envision all the people that have been benefiting from this coverage, it's really scary to think about what may come if that does proceed. So the progress we've made over the past 4 years is really an incredible testament to the work of dedicated individuals and organizations, such as in-person enrollment assisters and community groups that got involved with their local enrollment coalition, as well as to the importance of the ACA itself and the life-changing nature of this coverage to Americans all across the country. And our staff, volunteers, and partners encounter those Americans every day. I want to share one quick story. There's a woman named Kim Jones. She lives in Wake Forest, North Carolina. And she went for a long time without health insurance. In 2013, just as the marketplaces were launching, she heard about the Affordable Care Act. She sat down with an in-person assister and she got enrolled. In 2014, she visited a doctor and she found out that she had a tumor in her brain. In August of that year, she had brain surgery to remove the tumor, and at the time, she told one of the Enroll America staffers in North Carolina, quote, "The Affordable Care Act insurance saved my life." Sadly, Kim had a heart attack just this past October and had to undergo open heart surgery. Thankfully, she is recovering now. She's doing a lot better. But when she was actually in her hospital bed, she was doing press interviews because it was in the middle of open enrollment, and she thought it was so important to be able to get the word out to other consumers and help them understand the benefits that come with coverage through the ACA. So certainly all Americans deserve the peace of mind that the Affordable Care Act gave to Kim, the kind that comes from knowing that they can get treatment in the face of sudden illness, that tumors don't have to mean a death sentence or a lifetime of debt. But even as we have watched more Americans than ever gain the security of health insurance, we certainly, and this is no more true than it is in the last 24 hours, we've watched the law their safety is based on become less secure. So as we stand here today, no one can say with absolute certainty what comes next for the Affordable Care Act or the American Health Care Act. But what Enroll America does know with confidence are the needs of consumers now and in the immediate years ahead. Consumers' challenges became our challenges these past several years as we worked to remove the barriers to enrollment that they faced. And no matter what comes next, whether we successfully preserve the Affordable Care Act entirely, or it is repaired, or changed via repeal and replace, or something else entirely, the needs of consumers must be front and center as we go forward. So that's why I do want to spend the remainder of my time talking a little bit about the needs of consumers that we've learned over the last several years, and what that tells us about where we're headed. We know that people want health coverage, and they want the coverage that is made available through the ACA. The challenge we have faced each day in this work is not how to convince people that they should want coverage, but rather to identify and remove the barriers that may prevent them from successfully enrolling or keeping coverage after they enroll. 3 barriers in particular have important implications for what ought to guide the priorities for policymakers in the future when we're talking about connecting consumers to coverage. And that's what I really want to spend the remainder of my time on. In-person application assistance, cost is king, and also the importance of marketing and outreach work. So first, we have learned that in-person assistance and individualized help is essential. Consumers who receive in-person assistance are far more likely to successfully enroll. I remember in 2013 when the health insurance marketplaces were launched, I can remember President Obama in the Rose Garden talking about this being almost like Expedia, right? You go online, you choose your health insurance, and suddenly you're enrolled and you're happy. And certainly, things didn't go so well October 1st, 2013 when healthcare.gov launched. But even beyond that, even now that it is a fully functioning website, we've learned that when you're talking to folks, especially those that have been uninsured or may have language barriers or thinking about the audience we're really trying to connect with, they really want to sit down and talk to an expert. And more than ever, we need continued robust federal funding for the navigators who provide this in-person assistance in communities across the country, who are often the leaders in their local enrollment coalitions. And we need to continue to support online tools that make it easier for consumers to find and connect with those assisters, like the Get Covered Connector, which is a scheduling tool that Enroll America developed so that consumers can find the in-person assistance available in their communities. Second, we've learned that cost is king. When you're talking to consumers about the coverage options available to them, in many ways, this is actually not a healthcare decision for them, this is a financial decision. And it really all comes down to if they can afford the coverage available to them. Too many Americans still don't understand that financial assistance is available to help lower their monthly premium, and certainly the political turmoil surrounding the law in recent months has made it even more confusing for consumers to understand what is and isn't available and what has and hasn't changed. But when they do understand that simple fact, that financial help is available, they are much more likely to enroll. 83% of the 12.2 million Americans who enrolled in a plan for 2017 actually got financial help. So this is not something that a small portion of people are getting, but again, nearly 9 out of 10 folks. So this is an incredible opportunity for millions of families, but it's not the only way that the ACA has made coverage more affordable. Cost-sharing reductions, or CSRs, limit the out-of-pocket costs paid by more than 7 million Americans with marketplace coverage, or that's 58% of those with coverage for 2017. These cost-sharing reductions are critical to making health insurance affordable and healthcare accessible for those who receive them. And it is really vital that cost-sharing reductions be maintained even as discussions about changes to the ACA continue. And again, another example of why I think yesterday's actions in the House were so deeply concerning, because the American Health Care Act would eliminate cost-sharing reductions altogether. And in fact, the bill increases total out-of-pocket costs by an average of $3,600 for marketplace consumers. And a really staggering statistic in some research that's been done, it would raise premiums by $12,900 for a 64-year-old making $24,500. Again, making $24,500, it would raise premiums by $12,900. I don't think that's affordable. So, but let's suppose that, that Republicans are unable to push repeal and replace through the Senate. Well, remember that CSRs are not necessarily safe in that scenario either, and why even before the progress on the Hill this week, you were hearing from a lot of leaders in the industry major concern about CSRs. And that's because CSRs are at the heart of a federal lawsuit right now, and marketplace plan participation and prices for 2018 really hang in the balance. Without those critical financial supports, consumers may be left with fewer options for affordable coverage in 2018. So this is really an enormous priority that everyone's keeping an eye on that works in this space. Third, the last thing I want to touch on, and then I'll be eager for discussion, significant investment in outreach must continue for coverage efforts to be successful. We have learned that consumers must be engaged repeatedly. This is not about a one-time conversation. This is not about just having an ad play on a TV or handing them a flyer. It's about following up repeatedly and helping them through the process to enroll. While incredible progress has been made, millions of Americans who could benefit from the health coverage opportunities available to them today do remain uninsured. Reaching them and getting them to enroll will take multiple engagements from national, state, and local level outreach efforts based on proven best practices. Just a few examples of what this can and should look like. Federal agencies who interact with millions of individual Americans are in a unique position to reach out to and refer uninsured Americans who need assistance. Governmental and community organizations, they should be using email, calling, text, meeting in person with consumers until they successfully complete enrollment. Linguistically and culturally appropriate forms of communication and in-person assistance must be provided, especially for those groups that are most likely to have high uninsured rates. With a sustained and robust outreach effort from both nonprofits and the previous administration in place, we saw that enrollment in the marketplaces was steadily increasing. And a serious outreach effort in the years ahead by the new administration will be required as well in order to not only expand the number of Americans who have the peace of mind that comes with having health insurance, but also to ensure the stability of a system that has more than 12 million Americans depending on the coverage through it. Of course, we know in this political climate that we're unlikely to get everything we want. And as I said at the start, the outreach only works if there are options available that work for people. But the enrollment community will still be clear about what consumers need and deserve and push hard to get them as much support and information as possible. So, in conclusion, this journey has been intensely personal for those of us in the enrollment community who have worked to sit down one by one with our friends and our neighbors and to help them through the enrollment process. We face an uncertain future and a really scary future in many ways. And we're scared of what that means for our partners, for organizations that are right now completely unsure of how to plan for the months ahead in this climate. But most of all, we're anxious for the people that we serve. We know how much this coverage means to so many. And just as we celebrate the stories of people like him who have found life-saving health insurance and peace of mind for the first time in their life, I lie awake at night and worry about what might happen if this coverage is taken away. So the administration has the ability to make it harder for people to enroll or to otherwise undermine the marketplace, but they also have a great opportunity and a great responsibility to the American people to preserve and expand their access to affordable coverage. And now the Senate holds incredible power to determine if we will continue to make forward progress and build upon the gains that we've seen the last several years. Certainly not a perfect system, and I think those of us that are proponents of the ACA and have been doing this work could tell you lots of ways that it could be improved, and we'd like to see that happen. But certainly I think the proposal that we see in front of us is not the answer. We have seen what consumers need, and we have seen what works in addressing those needs. We are watching now to see whether a real effort will be made to address them moving forward. So it's important that the needs of consumers remain at the forefront of this discussion. It's always kind of striking how much that often isn't at the forefront of conversations in Washington about healthcare, and that Americans continue to make their voices heard, encouraging our leaders to work together to improve access to affordable healthcare rather than to take it away. Thank you so much.
Thanks very much. So our third speaker today is Dr. Robert Morrow, and I think you're going to have a easier time at the podium because you have to show some slides as well. So while you're heading up there, so Dr. Robert Morrow is the president of the Southeast region for Blue Cross Blue Shield Texas, and he's going to give us the perspective from an insurer. Blue Cross Blue Shield, the Alliance, the national organization, is actually partnered with Rice and several other academic institutions to get access to their claims data to do research on health policy issues that'll hopefully lower the cost of healthcare for everyone. So we're excited about that. And you've probably seen stories in the paper about large insurers, Anthem, Cigna, Humana, threatening to pull out of various different marketplaces. You will generally not see Blue Cross Blue Shield mentioned in those types of stories. So with that, I'd like to hand it over to you.
Well, thank you. First of all, thank you, Dr. Ho, and also the Baker Institute, Dr. Chu, Ms. Philibic, for what I think is a great conversation, and thank everybody here for being here. I feel a little landlocked because I tend to like to walk around when I talk, so if I'll try to stay relatively stable. I love the topic, by the way, and I'm going to give you a little bit of sort of a primer on Blue Cross and Blue Shield of Texas because I think it helps put my comments in context. So we are a member-owned company, which our plan president likes to say means we report to Main Street, not to Wall Street. And being member-owned actually helps inform some of the decisions we've made with regards to the Affordable Care Act. So in Texas, our purpose is to provide access to affordable care to as many Texans as possible. And so that's why we're the only insurer who actually provided coverage under the ACA in all 254 counties in Texas. The other thing you should know about Blue Cross and Blue Shield of Texas is we're our own company. We're part of the Blue Cross and Blue Shield Association. And also that about 80% of our business is group business. So employer-based business. About 10% is government and about 10% is retail, which is what my remarks are going to be mostly about today. So of our group business, they're predominantly self-insured. So these are employers who are really paying healthcare costs out of their pockets. So when Dr. Chu and I are having our collegial discussions about rates, we're predominantly discussing what somebody else will be paying Dr. Chu for care at his institution. So back to sort of our topic today. Blue Cross and Blue Shield, you may or may not, for those of you who are on a game show, actually health insurance as we know it today started with Blue Cross and Blue Shield of Texas almost 90 years ago. So we've been around through world wars, cold wars, Gulf wars, desert storms, the advent of Medicare, Medicaid, the ACA, and multiple administrative changes. So I would argue that health policy has pretty much always been unpredictable. It's just sometimes it's more unpredictable than others. And that's, I think, where we find ourselves today. So because I think looking at the past can sometimes, and the present can sometimes help inform for the future, I thought I'd just share sort of what was going on in my world 4 years ago, which is when I joined Blue Cross and Blue Shield of Texas. I'm actually a family physician, and I came from working with Texas A&M Health Science Center as sort of a healthcare outreach institute at the time. And so when I joined, it was in 13, and it was as we were gearing up to try to encourage enrollment on the ACA exchanges. We put a program together, it was our Be Covered program, where we worked with a number of mostly local, community, civic, faith-based, educational, government-based programs to try and get the word out to people who would benefit from signing up for coverage under the ACA. And I think this is critically important because, one, I would argue all healthcare is local. And this allowed people to hear about the ACA and their coverage options and what they could do in terms of signing up for insurance from people they knew and trusted that were in their local areas. The other reason this coalition became really important is what happened after they signed up. Anybody think healthcare is a little confusing? Anybody think maybe health insurance is really confusing? Well, think about it if you were one of these folks who've never had insurance before. You don't know a copay from a deductible, from a premium, from anything. And you're now all of a sudden signing up for something that you may or may not even understand. So we were able to leverage this coalition to also get education out to people who signed up for insurance, because of course, once they got it, we really wanted them to use it, right? We wanted them to use their insurance. So here's kind of the data. Here's what happened. This is part of the reason I have slides, so I can actually put numbers up rather than trying to remember them. And I think this is actually pretty powerful. And Ann kind of went through some of these nationwide. These are state numbers. So 14, that's everybody who signed up in Texas under the ACA is that number, 733,000. That's both Blue Cross and other health insurance plans, although I will tell you Blue Cross was the bulk of that. The next 2 years are our retail numbers, just for Blue Cross. But the bulk of those retail numbers are people who signed up under the ACA. So this is kind of huge. But what I'm really proud about is actually the next slide. So these are people who signed up for these plans in each year who actually then used their insurance. So look at that in 2014, 370,000 people went for a well visit. Now the 370,000 is a big number, I think, but just think about if you were one. If you're just one of those people, you've never had insurance before, you may never have had the opportunity to go for a well visit before. Your experience with our healthcare system was the emergency room. And now all of a sudden you can go and get a well visit. For you, that one person, that's a really big deal. And the best way to access healthcare in our country is through your physician or other provider. That's really the most appropriate. It's the best access into our system is to have your own provider. So the fact that many people established a relationship with the physician is big. The fact that maybe they identified, as Ann sort of took us through a story, a problem that could be treated when it was a much less expensive, much clinically sort of safer problem than had it been allowed to go on before it became something that got them to the emergency room is pretty huge, I think. Now, for us, this didn't come without a cost. So it's been pretty well reported. Our first year on the exchange in Texas, we lost a little bit north of $400 million. I mean, that's a lot of money. The next year, it was a little bit north of $300 million. We're doing better this year, or in 2016, our numbers say that for about every dollar we brought in premium in 16, we paid out $1.08. So still a little bit of a losing proposition, but getting better. We're learning. And so people ask, okay, so why did you lose so much money? How did you not know sort of what you're getting into? Well, there's probably three main reasons. Number one, and to be quite frank, we weren't alone in this. Pretty much everybody across the country completely underestimated the disease burden that existed in the population of people, patients who signed up for health insurance under the Affordable Care Act. I've never actually wanted to be an actuary, nor should I be one. Math is not necessarily my strong point, but I can't imagine how difficult it would be to be an actuary at this time trying to make predictions about appropriate premium rates for a population that has largely not been cared for by insurance before. And so I think that was a big part of the cost. The second was, quite frankly, the way the rules were written. In terms of the payment and the ability to sign up at really pretty much whenever you wanted through special enrollment periods, made it really easy for people to just sign up for coverage when they needed some kind of a test or treatment, and then drop back off of the exchange. So there was a lot of this sort of shopping going on. And then the third thing, which was not unique to just the ACA population, back in 2014 is when we really began to see a pretty significant increase in prescription and specialty drug prices. So they had been kind of flat or even trending down until around 2012, and then they started, and 14 is when they really started to come up. So a number of reasons it did that. So where are we now? As we prepare for 2018, there are really three things that we think are critical that need to at least remain in place or somehow be addressed in order for us to continue to provide affordable coverage under the ACA or whatever evolves out of the Senate. And one has already been mentioned, and that's cost sharing reductions. That's really actually huge. About 85-ish% of the people who enrolled through us on the exchanges got some form of a premium subsidy. And as Ann has already mentioned, about 60% of those, in addition to that premium subsidy, got cost-sharing reductions that helped them with the out-of-pocket costs associated with getting health care, co-payments, deductibles, things like that. And without those, there would be a significant increase in premiums in order to try to get these the plans priced correctly. So the cost-sharing reductions, as already been mentioned, is a pretty big deal. The other is the individual mandate. I think one of the very popular components of the ACA is the guaranteed coverage, guaranteed issue. And in order to be sort of financially sound, either the individual mandate or something that effectively replaces it really needs to exist, whether that's a waiting period or some sort of a time you have to have been on insurance. And there's a number of different ideas out there, but something that addresses the issue that the individual mandate was meant to address really needs to be in place. And then stabilization funding. So stabilization funding is funding that allows for states, we hope, to put in place things like high-risk pools or a reimbursement, a reinsurance program that helps protect against those really high-cost, very sick individuals in the overall insurance pool. Just for those who are legislatively aware, right now there are two bills, one in the House and one in the Senate in Texas, as we happen to be in a legislative year. And this is important, that would allow the Texas Department of Insurance to actually establish high-risk pools or a reinsurance program. The reason that's important is the Texas legislature only meets every other year, and so it's likely that whatever comes through the Senate will be after the Texas legislative session has finished, so those two bills are pretty important. I mentioned just real quick a few more things about cost sharing reduction just because and these are just numbers. Premiums will go up, we estimate about 20% without those. And that actually results in, again, I've already mentioned I'm not a math genius, but our guys who are say that actually will result in higher cost to taxpayers through increases in premiums, and then the subsidies that are used to fund those premiums would then have to go up. So that, again, just underscoring the importance of cost sharing reductions. Not to act like that health policy is only a national issue. I thought I'd finish by talking a little bit about what's going on right here in Texas. And some of you may have flyers about Where You Go Matters at your tables. And so other things that drive up costs, not only for our on-exchange populations, but basically for everybody, for healthcare, are this problems around freestanding ERs, which seem to be popping up next to every Starbucks or Chick-fil-A or something across metropolitan areas. I'll give a shout out to Dr. Ho and her team who've done some just, I think, landmark work on looking at the costs and the issues associated with this just dramatic growth of freestanding ERs, particularly in the state of Texas. And so there are right now 11 different bills in the Texas legislature that are dealing with freestanding ERs from a number of different things. One happens to be some transparency, so that it's made very clear whether or not that ER and the physician are in or out of your insurance company's network when you go in, and also what the costs may be. So it's really important legislation. The other issue is there's another bill, I believe it's 3124, House Bill 3124, which deals with our ability as an insurance company to provide data, outcomes and cost data to physicians who are working within an accountable care organization. As Dr. Chu really eloquently took us through in his remarks, one of the good byproducts or products of the Affordable Care Act was really pushing us even faster into working with our providers in establishing value-based care programs, of which accountable care organizations would be the programs that most people think of. So this bill would allow us as an insurer to share data with our physicians who are working within those accountable care organizations so that they can better understand the cost implications of the care and treatment that they provide. This is pretty critically important. I'll ask a question before y'all all get to ask them. So anybody know what the single most expensive piece of equipment that every physician has at his or her disposal? I carry mine with me all the time. It's that. So as a family doctor, I took in about 6 cents on the dollar of the healthcare. So about of all the healthcare spend, I as a primary care docs get about 6% of that. So relatively low. But I control about 60% of it. Don't you think it'd be a good idea if I actually understood the implications of what I'm using this pen for? So thank you all very much. Look forward to questions.
Thanks so much, Dr. Morrow. So now I'm going to hand it over to the audience. You are welcome to ask questions, although I reserve the right to interrupt at any time and ask questions that I want to. So we are recording this so other people can watch the discussion. So please raise your hand if you have a question. We're going to bring a mic over to you so that viewers can see what is going on as well. So please.
Yeah, the Affordable Care Act was passed with one of the premises was to try to bend the cost curve of medical care. And I think most people, believe, and I think the data is there, that, Medicare is heading toward a crisis. And this was part of the problem to solve that. Kind of what's happened that wasn't assumed before? And then the second thing is, what is the answer to that? Because I think, to me, we got the Affordable Care Act issue and we've got Medicare issues, funding of that long term. And I don't, like I said, I'd like to understand that a little better.
I think that one of the things that if you actually look at, of course, it's what graph you're looking at and how you account for it. But actually, if you look at the national trends after the Affordable Care Act, the trends actually did moderate quite a bit. But what I think is happening now is there's a demographic explosion, and there's also what Bob talked about. When you bring a lot of people who probably access care, the uninsured access care about 2/3 of the rate that the insured population did, at least previous to the Affordable Care Act, and it was mainly through vehicles like the emergency room. But then you start to bring people in to the care delivery system, and all of a sudden you're discovering a disease burden that wasn't really there. You know, in the short term, you're going to see rises in costs. But I think if you're looking at the trend lines going forward, it's really the 10,000 Medicare beneficiaries a day that's coming into the Medicare system that's going to drive a lot of those costs overall. Pharmaceutical costs, last couple of years been this year is a little lower, but last few years has been double digits. In our hospital world, it's been 10, 12, 13% increases. So the pharmaceuticals now account for 11% of total dollars or thereabouts, and climbing. You know, cancer drugs. You know, typical biologic cancer drug is now a couple $100,000 per course, right? When you think about it. So those things are happening. The technology is changing, the delivery system's changing. So whether we can actually extract savings out of the system from waste, taking out the waste of the system to help pay for some of these things that are inevitably going to start happening. I think that's the $64,000 question. Actually, more than 64,000 now, right?
Yeah. Dr. Ho.
Yes, please.
I'd like to respond to that too, and echo some of Dr. Chu's comments. I think there are a number of issues that, if I mention healthcare is complex. So first of all, you have a disease burden. So you have to deal with a number of people who are accessing healthcare and who've never accessed it before, and so in ways that we haven't actually been accounting for either. So we're having to learn a little bit about the population, which for our group customers, this is actually a good thing. All the data that we're learning about this population actually serves our whole population of members very well. So I think that's one issue. I think the other issue, and I think this maybe is a promise at this point, although we're seeing some good results, is as we're pushing to work more with our providers, and actually quite frankly more with our employers, around value in healthcare, putting value in healthcare, i.e. with value being a simple equation of quality over cost, where you pay attention to both the quality and the cost, and you bring really the provider community very robustly into that mix. There's going to be a lag time before the benefits of that begin to play out. So I think in some regards we're dealing with a timing issue. And then as Dr. Chu also pointed out, you know, we didn't necessarily anticipate the explosion in both prescription and specialty drug prices that has happened 3 or 4 years ago and just continues at an astronomical pace. Actually, Dr. Chu, our data shows us that of every dollar premium, 21 cents of that now goes to pharmaceutical. So a lot of different compounding variables that lead to the cost of healthcare.
Thank you. You have a question over there?
My question has to do with what is considered one of the failures of ACA is having the young and healthy not enrolling, basically not having that income in terms of premiums. What is the impact on that, on the actual cost increases that we have seen in the last couple of years? How many, because of when insurance drop out of the program? And also, what are some of the latent issues when these young, healthy individuals are no longer young and healthy and then actually need the health care?
Ms. Filippic, do you want to take
Sure,
that
I'll
first?
start, and I think Bob probably has comments there too. Well, first of all, I would say certainly we need healthy people generally. That's something that I've heard, that we focus a lot on young people, but we should be thinking generally about healthy people. And actually, when you look at the different populations and rate of enrolling, that the young population has actually been one of the groups that's seen a larger drop in the uninsured rate. So we actually have made significant progress, but I think the underlying question that you're raising is right. And partially, I would say, and this goes back to one of Bob's comments, that the mandate here really matters a lot. And I think part of why this is a process of people learning about the mandate and frankly, having to pay the fine that's associated with it. And we're really just at the point now where that fine has peaked out at $695 a year. And I think so I don't think that we have seen, if you think of the motivation that comes from that fine, I don't think we've really seen the results of that yet. So that's why I think part of the concern of removing the mandate in the proposals in the American Health Care Act is so concerning to so many, because the expectation is that people that don't need coverage, don't desperately need it, right, aren't sick and aren't looking for that health care immediately, are not then so motivated to enroll in coverage, and that we would see costs go up for everyone. So that is a major concern, and why I would say that the mandate, I don't think anyone was excited to include that in the Affordable Care Act, but the recognition from economists is to sort of even this all out. We need a motivator to get folks that are healthy, perhaps young, and not so risk averse to get in the door. And again, I think that were the Affordable Care Act to continue on, I think that we are just now starting to see the results of having that mandate in place.
Dr. Morrow?
Well, I mean, I would echo that. In terms of why they don't choose to sign up, well, I mean, I can sort of remember back when I was young and invincible, but that's becoming a lot longer ago now. But Ann is, thanks for the laugh for that, by the way. Ann is completely correct. I mean, it is economics. You know, if you're going to that's how insurance works, is you have a number of people on who don't really need to have the high cost paid for on their behalf, and that's helped in part by folks, the folks who don't need the high cost are helping those who do. And so, as I mentioned, it's one of the sort of three things that we have put out there as critical to address in order to go forward.
Thank you. Another question? Mr. Shapiro, right here.
Yes, my question, Dr. Morrow, is if the bill passed by the House becomes law, what is your estimate for your company or in Texas of what will happen to retail premiums and to coverage?
Well, a bit hard to answer that since it just passed yesterday, but I can tell you that if you looked at the data that I put up there, without cost sharing reductions, I think the estimate I had was about 20% increase in premiums, and I believe there's about a similar percent increase in premiums without an individual mandate. I think that's what I had out there. Ken's shaking his head, so maybe that's about what he's seeing too. And then, as I said again, my understanding, without the cost-sharing reductions, that increase in premium leads to an increase in subsidies, because as the premiums go up, those who are eligible for subsidies will, of course, get more in subsidies. So there's still a taxpayer burden associated with not providing cost-sharing reductions.
Of course, in the hospital world, we'll probably see a higher burden of bad debt, you know, even higher than now, which would make our negotiations with Blue Cross even nastier, right?
But in a pleasant, nasty way.
In a pleasant, nasty way.
Someone has the mic back there.
Good morning. I wanted to first and foremost thank each of you for your work in your respective areas and for allowing Houston to have a transparent, open communication dialogue with health leaders. It's very appreciated and actually refreshing during this time of uncertainty. With that being said, I just wanted to mention, I hear Ann mention marketing and outreach and the need to really focus on that as we move forward in the future in regards to enrollment. And I'd like to just plant a seed and let you know that one of the most effective ways that we can do that is through utilizing Spanish language media. And I represent Univision Communications here in Houston, and they've hired me on board to claim that stake and really impact and lead conversations in reducing healthcare disparity, because we exist to not only entertain and inform, but also to empower, and we take that role very seriously at Univision. So I'd like to kind of plant that seed to the audience as you look forward to how can we really engage with a strategic, measurable Hispanic strategy in Houston and nationwide. Thank you.
Thank you.
One thing I'll just add, totally agree. And actually, after the first enrollment period, we did extensive research to try to understand, of all the different methods we were using to engage with consumers, what was really landing. And one survey question that really jumped out at me was, we found that the number one way that people were getting their information was through the media, and TV in particular, local TV, was the most powerful thing. And that actually led to us, we do work with Univision, and I do think Spanish language media, especially when you're looking at the audience we're trying to reach, is essential. But just generally spent a lot of energy in creating local TV partnerships. So I will tell you, in Washington, D.C., most groups are focused on the New York Times and the Washington Post, and very sort of these resources that I might be reading every day, but when you're looking at the uninsured population, it's probably not where they're getting their information. And so I'm a big believer in getting local, and again, partnering with organizations like Univision that can really get right to who we're trying to reach.
And the highest numbers of the remaining uninsured in this country are actually Hispanic.
And I would just echo that, the Be Covered campaign that we did really highlighted the importance of involving local leaders and local community groups that this population of patients are used to going to for information. They're trusted sources, and so I think that's critically important. So thank you for your comments.
Yeah, I just wanted to expand for a second on the question about the impact of the HCA bill on both prices as well as enrollment. And as Ann said a few minutes ago, the bill that was passed yesterday, if it became law, would allow insurance companies to change rates so that to encourage young people to sign up, you could have a rate that was a 5-to-1 ratio. So the ratio for the most high age, like a person at age 65 compared to a 21-year-old, could be 5 times more than the 21-year-old rate, right? So that would mean reducing rates for young people, raising rates for older people. At the same time, the subsidies would change to be based purely on age and not on income anymore. So, and the amount of subsidy that older people would get would be dramatically reduced. And so the point about insurance premiums potentially being $12,000 higher for a low income older person would basically take the people with, frankly, the highest disease state and make it much more unaffordable for them, because you wouldn't just have the 40% rate increase that Bob and I both think would happen with the combination of no mandate and no cost sharing reductions, but you would have even a higher rate of increase for those older people. And so if we look at our population that we serve right now, we have about 150,000 people that we cover with subsidies under the Affordable Care Act. Just absolutely devastating to the 40,000 or so that are over age 50. Just I don't even know what would happen to those. So that's probably the worst thing. We may pick up a few more healthy young people because of it, because we would reduce rates a little bit for young people, but it's just absolutely catastrophic for people, low income people that make $25,000, $30,000 a year and over age 50.
Thank you, Ken. We're here.
Oh, I've been enjoying the conversation a lot, and we've been talking about the marketplace a lot. But another huge component of the AHCA and another big uncertainty about the future of healthcare involves changes happening to the Medicaid program, especially when we talk about block grants or per capita caps, or what the CBO estimated about an $800 billion reduction in federal funding for Medicaid. And so I just wanted to know what your thoughts about the future of delivering healthcare with changes for the Medicaid program.
Well, I think that you're absolutely right. If you actually look at what's in the AHCA, there are big implications, not just the per capita cap or block grant proposals, but the way the treatment of Medicaid expansion, right? Right now, there's a 90% threshold of funding from the federal government, paid for, by the way, by that 3.5% surcharge on the wealthiest individuals. So that was also rolled out. So the funding for a large part of the expansion goes away in the AHCA. In addition to the plan changes in Medicaid. And there are some provisions to allow people who are in the Medicaid program to keep it. There's a phase out of the extra federal share of Medicaid, but really when you think about it, even before per capita caps and block grant, the trend line will be downward for states that expanded Medicaid. So I think that the Medicaid population, Medicaid expansion will definitely erode. And then you add on top of that a per capita cap that doesn't necessarily grow, whatever it is, medical GDP plus one or whatever it is. It doesn't take into account the mix of the population that could actually become Medicaid eligible. And remember, the Medicaid population is not a static population. It's quite dynamic. Every 6 months, every year, there's a huge turnover rate. So even if you guarantee that the people who continuous enrollment will keep that Medicaid, that in 5 years, the complexion of Medicaid will change dramatically. So. And that's another reason why the CBO, when they looked at the bill, talked about at least a 24 million member drop in coverage. It's not just the exchange population; it's huge numbers of Medicaid patients that would drop off. Now, a state like Texas, we didn't expand Medicaid. There's sort of it's intriguing to think that maybe we would go in and for an 1115 waiver, expand Medicaid, right, in some ways, under whatever rules, under a per capita cap scenario. But remember, Texas, if you actually look at the per capita spending per member, is one of the lowest per capita spending. So if we lock in that low per capita spending with or without the expansion dollars, by the way, it came from California, and I don't know if you know, but California actually took in $20 billion more a year from the federal government for its Medicaid expansion population. $71 billion in total federal dollars for Medicaid expansion. $20 billion went to California. $3 billion went to Ohio, by the way, where John Kasich is pulling out his hair thinking about how am I going to cover the 700,000 people that are covered there. $3 billion went to Kentucky. They're pulling out their hair. Well, I don't know if they are or not there, but they're definitely a risk in Kentucky. $3 billion to cover 700,000 Medicaid expansion members in Kentucky is a big deal. It's a big deal. And those are the coal miners and other people who, are not employed, and they're not likely to get employed because coal's coming back, right? And so, so I think that there are very broad implications to that policy. I would love to see Texas expand Medicaid under some favorable circumstances, but I think that you have to look at what the baseline is and what the rules are for adding people, in a downturn, or adding people who if Texas 85-year-old and older population grows, right, or even 75 and older, and you have more dually eligible, Medicare and Medicaid dually eligible, that's going to increase our costs. And so you have to look at the outlines of the overall plan. So it's a complex, I know I don't want to be too wonky here, but it's a complex issue, Medicaid expansion, and the implications of the repeal bill on that. But it's very, very, I think that if you really look at that bill, whether we think it's a good thing or not to expand Medicaid and whether we can afford it going forward, the implications are pretty severe overall.
Good morning. My name's Marianne Matsu, and I'm a registered nurse. My question is, with the growing Medicare population, do you foresee the age of Medicare enrollment rising from the age 65 to 70?
Well, that's been debated, right, for a long time. A stepwise progression in the age. I mean, when 1965, the lifespan was not that long. Now the lifespan, if you make it to the age of 65, actually I know California because we were steeped in that. But if you make it to the age of 65 in California, you're likely to live till the age of 90. Right. So, and I think that's generally true. It's a little different state by state, but your life expectancy goes way up. So, the demographics the actuarial analysis at the beginning of the Medicare program is very different than it is now, which is one of the reasons why everyone's so worried about the trust fund and whether it's viable. I think that there's got to be some ways to adjust the costs of Medicare. Right now, it's just trying to squeeze the physicians, the hospitals, the durable medical equipment makers. But there's got to be some other solution, whether new infusion of dollars or a delivery system reform mechanism that coordinates care, cuts out waste. Something has to happen. I actually think politically it's very hard to raise the age of Medicare. I think it's very hard to do that. Social Security, went up, the age for that is gradually going up, but Medicare is health care. And you think about who are the tier of population that needs it the most at this point. It's the 55 to 65 population. And if you look at that population, they're very sick, 55 to 65-year-olds, and to ask that population to wait another 2, 3, 4, 5 years, throw themselves to the individual market, the retail insurance market, where it's going to be 5 times more expensive to get health care, it's actually a lot to ask that population. So I think politically it's really going to be hard to do.
We're going to take one more question and then we have to wrap up.
I wonder if you could contrast the way the government handles reimbursement for drugs through the Veterans Administration and the way it handled with Obamacare. As I recall, when Obamacare was passed, there were restrictions on the government having negotiations to fixing the prices of the drugs. But I'm not aware that the same rule applies to monies paid out through the Veterans Administration.
Yeah, actually, that's a very good question. How do actually not just the VA, but how do safety net hospitals access better drug pricing and the Medicaid program, right? Because for 20-some years, there's been the Medicaid best price law, which actually mandates that the best discount you give to whoever it is, you have to give to Medicaid, right? Now, there are problems, economic issues on that, but the VA has the 340B program. The safety net hospitals actually can access the 340B program, which is preferential pricing for pharmaceuticals. Now, in a lot of ways, it's squeezing a balloon, right? So I think if you look at the pharmaceutical, I don't want to speculate on pharmaceuticals, but if you squeeze on one end, there's going to be pressure to expand on another end. So I think that one of the things that happened with Medicare when we went to the drug coverage for Medicare is specifically there was a prohibition against Medicare negotiating drug pricing, because Medicare would be a huge user of drugs. So you're squeezing on Medicaid, you're squeezing on the VA and the safety net. If you start squeezing on Medicare, then it's where else are you going to cost shift to? I mean, that would be the problem with doing it that way. But I think that if you actually look at the pharmaceutical industry, it's a very complex industry. You hear what they say about R&D, the need to plow more money into research and development, sales and marketing, whatever it is. And there are a lot of open questions as to whether or not the industry really needs those prices to support the economic model. And I don't want to get into it because I don't want to put my foot in my mouth at this point.
Well, okay, on that note, we've run out of time, and so I'm going to wrap things up. I'd like to thank our panelists for excellent presentations and a terrific discussion.